So
Okay.
Dr. Boccia is currently the professor of child and family studies at Baylor University. She is trained in developmental psychobiology and neuroscience and conducts research exploring quality of attachment relationships, including sexual behavior and their impact on stressful experiences. As a licensed therapist, she provided sex therapy for patients with and without cancer at the Center for Sexual Health and Education in Charlotte, North Carolina. She has held faculty appointments at the University of North Carolina, Chapel Hill, where she was the director of a research core for an NIH-funded mental retardation research center, the Gordon Conwell Theological Seminary in Charlotte, where she taught and directed the training of master's students in counseling, and at other universities. She is a licensed marriage and family therapist, a Texas MFT supervisor, an AA MFT clinical supervisor, and an AA SECT certified sex therapist. Now, all that alphabet soup, I do not have a clue as a perinatal nurse, completely outside of my realm, but you can fill us in. The floor is yours.
It didn't occur to me you're going to read it all.
Oh, you know.
Yeah, I've had a long and winding career, shall we say. I started out studying monkey behavior.
I'm going to turn off my video. When you get to 25 minutes, I'll turn my video back on. That'll mean you have 5 minutes to finish up and take questions.
Okay. Okay, so which screen are you seeing?
We are seeing the slideshow that says sexual dysfunction in brain cancer patients.
Great. Okay. Okay. So my background doesn't make you think automatically about working in cancer, but when I came to Baylor, I looked around to see how I might contribute in terms of a service, and I connected to the people working with cancer patients to go to support groups and talk about sex after cancer. And it was such a success with the patients that the nurses and social workers and other support people asked me to come and do an in-service. So I did that. And that led to a continuing education event. And that led to my meeting Dr. Ekobe Fonkem, who's a neuro-oncologist. And he invited me to be a keynote to talk about this issue at one of his neuro-oncology conferences that he created. So that's how this started. After the talk, he came up to me and said, can we do some research together? Because this was clearly an area that people haven't looked at a lot. And so I said yes, because for me, you know, sexuality is so connected to relationships and healthy functioning that, that I was all about it. So now, one of the things, of course, about cancer is, it's not the death sentence it used to be. A lot of people are surviving for years, if not decades. And so as survival has increased, it's not just about that anymore, but about the quality of life that people experience. And so quality of life is defined as a personal sense of well-being. And it includes being able to do what you want to do physically, psychologically, and so on. And so because medical interventions in general, but cancer especially, really impacts people's lives. If nothing else, just the word scares people. And so it can have impact that kind of echo through all of people's lives. And indeed that the survivorship care planning from the Institute of Medicine actually says we ought to be including discussions about how these things affect relationships and sexuality and so on. Now, before I got into this, and as I was viewing the literature, it looked like a lot of studies of sexuality in brain tumors, they used a quality of life questionnaire that had only a single question on it. And interestingly, of all the questions on the survey, that was optional. So a person could just decide not to answer it. And so people really didn't know a whole lot about what was going on with people when they had brain tumors and were treated for them. What research was out there was mostly on pituitary tumors. And that makes sense because obviously pituitary tumors affect hormone function. And so they were attended to. although the distinction between the impact of the tumor and treating the tumor wasn't really explored. Once we go beyond pituitary tumor, there's a little bit of information, at least in terms of these very simple measures. And they indicate that both men and women have high rates of sexual concerns when they get this diagnosis and treated for it. Men with pituitary tumors definitely have a high incidence of sexual dysfunction, but it's also high among women. And in fact, overall, higher among women than men for all kinds of brain tumors. And it seems to be that all the domains of sexual function are affected. So what we did was our first pass was basically to ask the question, what's going on with these people? And so I identified validated questionnaires that are used in sexuality research, including the Female Sexual Function Index, which is a validated, reliable index that's been used extensively for years, the International Index of Erectile Dysfunction, and a premature ejaculation profile. Turned out PE wasn't very common in them, but the ED function scale was really useful. We also used one of the typical quality of life scales. We asked about what kind of cancer they had, where it was located, and what treatments they'd been through. So that allowed us to kind of get an overview of what was going on in this situation. So we almost had 60 people participate, but predominantly female. This was done at the Baylor Scott and White Neuro-Oncology program. And after we consented them, we just simply asked them to complete these surveys. So the quality of life gives interesting subscales. There's physical well-being, which kind of makes sense. Social well-being relates to family, friends, and their partner or spouse. Emotional well-being looks at their mood, sadness, satisfaction, anxiety, all that kind of stuff. Functional well-being is tasks of daily living. Can they actually, do they sleep well? Are they able to work? Are they enjoying their lives? Do they have physical limitations that keep them from doing their normal activities? And then there's a section on special brain cancer concerns. As you can imagine, a brain tumor is going to have a lot of potential to impact cognition, emotions, personality, and so on. And so there's a whole section on special issues related to cancer, brain cancer, that asks things about numbness and mobility and vision and things like that. So in terms of the quality of life, it was pretty similar across males and females. Maybe brain cancer subscale was a little higher for males than females, but none of them were statistically significant. With the Female Sexual Function Index, there are cutoffs for when things get defined as clinically. And this scale is used a lot with research on pharmacology and stuff that might be helpful. And so there are separate scales for the different aspects of sexual function, including desire, arousal, lubrication, orgasm, a general satisfaction, and a pain scale. And one of the things that we know from research in sexuality is that satisfaction doesn't correlate identically with the physical aspects of it, like lubrication and orgasm. But although pain can certainly override everything. But this gives us a cutoff point to ask, where are these brain tumor patients in terms of their sexual function in comparison to the general population? And what we find is across all of these measures, it's more or less double. So you see here the percent meeting clinical criteria, and then the column on general prevalence. Most of them go pretty much around twice as much as the general population. So that's a pretty significant impact on these patients. And it clearly is something that needs to be addressed. If we looked at the quality of life in relationship to these measures, social well-being was positively related to all of these. That is, the better their scores were for desire, arousal, orgasm, and so on, the better their social well-being score was. The grayed out ones were less than 0.05, and functional well-being also had an impact on some. Now, interestingly, the social well-being scale only has one measure related to partners. So this is more about families and friends than about whether or not, I mean, otherwise you might think, well, sure, okay, if they're not able to function sexually, then maybe, I'm sorry, that was the social well-being scale. The social well-being scale only has one question related to their partner. And that came out highly significant with all of these parameters except for pain. So there's some idea here that family, friends, maybe it's got to do with social support, makes a difference for these people. And of course, this is a correlation, so we can't point to a directional in terms of cause, but there's a pattern here. If we look at the males, we had many fewer of them, unfortunately. We had, I forget what I said, 13 or so. And not all of them reported, but the vast majority reported some kind of sexual dysfunction. So as you can see, more than half of them reported moderate to severe erectile dysfunction, and they also all reported in other areas as well. When we looked at the type of brain tumors we were looking at, glioblastoma is the most common kind, and meningioma is not far behind it. The others were too few to look at separately, so we collapsed them into one variable. And it turned out that the men with the meningioma had the highest most frequently reported erectile dysfunctions than the other types. And years since diagnosis didn't matter quite so much. You'll notice that the glioblastoma is lower, and that's of course because that is the most aggressive and cancer that has the highest mortality rate, shortest life expectancy. I think right now the estimation is 14 months, although there are people who survive substantially longer than that. So obviously what we found was that sexual dysfunction was like twice the prevalence in the general population. And for women, since we had enough subjects to look at it, quality of life and sexual function was correlated with social well-being in terms of quality of life and to a limited extent functional well-being. But men were also struggling, and one of the challenges is that we don't know how that impacts things like treatment decisions or reaction to the cancer diagnosis or survivorship. We do see that it's impacting quality of life, and so one of the questions that this raised for us was, well, what's going on between them and their partners? And so our follow-up studies, which once we get IRB final approval, we will be launching, we'll be actually repeating this with some additional measures and including partners and spouses, so we can look at the dynamic of what's going on between them. But in the meanwhile, what do we know about how to help people in this situation? And unfortunately, there's not a lot of studies on sexuality interventions with brain tumor patients. I think like many serious cancers, I mean, glioma especially, glioblastoma, it's a lot of concern about surviving and treating the cancer. And people look at function, but they don't pay much attention to the relationships. And so there's very little in terms of relationship intervention and particularly sexuality interventions. But since partners are so important, first of all, for quality of life and sexual functioning, obviously, it's also really important to look at this in terms of survivorship care planning. And in fact, patient satisfaction with care is impacted by how well healthcare providers communicate with them. And so that's, again, another layer that we need to pay more attention to. Patients want information about sexuality. When they're asked if they want to understand this, they're yes, they're all over it. But patients also don't ask. They want to know, but they don't ask. They want the healthcare provider to raise the subject. Most healthcare providers not asking. And one study looking at medical students found that 80% didn't think they were prepared to address sexuality with patients, which explains why they're not asking. And obviously, if patients want this information, we have to find a way to get it into the conversation with them, right? To help them understand what's going to happen, what kind of impacts are likely, and so on. And let's see. So again, in the cancer survivorship plan, this is an issue that needs to be talked about. And there are a variety of interventions for sexual dysfunctions, but they're not really looked at in this patient population. Now, interestingly, anecdotally, in my experience, because obviously I did sex therapy and I worked with patients, and my experience with nurses and social workers and so on who were running these groups that I would visit. If the patient is going to actually ask anybody, they're going to ask people other than the physician who's treating them. They don't ask the oncologist. They'll ask the nurse. They'll ask sometimes the receptionist, but they don't ask the physician. So there's an opportunity here. And it turns out that there are some pretty simple tools for evaluating healthcare, evaluating sexuality in the healthcare. There are brief surveys. There are ones that you can just incorporate into, the initial information. You give them that clipboard and say, fill this out. Well, you can put a few questions in there that can trigger a conversation. There are also things you can do with a few brief oral questions. And part of the challenging thing about sexuality is it's not simple. There are psychological factors, social factors, physiological factors, treatment-related effects, all kinds of things that impact sexuality. But once the subject is broached, it's possible to find out where their concerns are. For example, with just so simple with menopause, the loss of estrogen results in all kinds of genital changes and sexual desire changes. Very often, this is when painful intercourse emerges because of changes in the vagina because of loss of estrogen. And there's things to do to help these people continue in their situation. So there's both medical and psychological. As a sex therapist, I would say sex therapy can be really helpful. I've worked with a number of patients with various kinds of things, including different kinds of cancers, men with prostate who are struggling to maintain their ability to perform sexually. I've been able to work with and help and women with breast cancer and dealing with the changes. A lot of things related to body image come up, and reframing things and helping them to find ways to work with or around the physical stuff going on in their lives can be very productive. And of course, you all know that's one of the things that's really valuable about team medical groups, that you can work together with physical therapists, with counselors, with physicians, and so on, and really help patients around all of the areas that they're concerned about. So we look at pharmacological stuff, medical stuff. We all remember when Viagra hit the streets. All of a sudden, the rates of diagnosis of erectile dysfunction went up tremendously because men would never talk about this. But when there was a drug that could help, they went to the doctors. So the PDE5 inhibitors, which includes Viagra and the other couple that escape my mind right now, are available that can be taken orally. There are also implantable systems. There are vacuum pumps and implanted systems and so on that can be used. Interestingly, one of the things we know from research is that these systems work best when they're supported by therapy. People have to, you're bringing something into the sexual relationship, and people need help in figuring out how to incorporate it without making it an additional barrier to a satisfying sexual relationship. For women, hyposexual desire disorder, which HSDD, low desire, is the most common dysfunction. And there are obviously a lot of stuff going into that are psychological and social, but there's also pharmacological, physiological stuff. And so the pharmaceutical companies have been working really hard to identify what used to be called the female Viagra. Of course, it's not about arousal, it's about increasing interest in sex. And there are two drugs that actually have FDA approval, flibanserin and bremelanotide. They work on different mechanisms, but they both increase desire. And they've been, randomized clinical control trials, have been done showing effectiveness of these in helping. Again, therapy is really helpful as well as alongside. Female arousal, which again, all of them came up. Lubricants, hormone creams that are used directly in the vulva can help. And there's a lot of different ways that they get applied, but there are things that can help with arousal disorder. Pain is another thing that comes up commonly with women, especially if there are hormones that are getting depleted in the system that are making the tissues of the vagina more fragile, thinner, less able to lubricate, and so on. Those things, obviously, some of them have to be addressed with the hormonal and lubricant arousals, but the pain thing can come from a variety of different sources. And there's a lot of research looking at that. But it turns out pelvic floor physical therapy is tremendously effective. I've worked with a number of women in my therapy system where they were experiencing pelvic floor pain, painful intercourse. And I actually had a student at Gordon Conwell who had so much vulvodynia that she had to wear boxer shorts and skirts because anything touching her hurt. So there's a whole range of how severe it can be. And but pelvic floor physical therapy works tremendously. I actually have a colleague who's a cancer survivor who also had this problem with painful intercourse. And I persuaded her, she was skeptical, to go to pelvic floor physical therapy. And not only did it resolve all the painful intercourse stuff, but the PT found adhesions inside that were a result of the surgeries related to her cancer. And she was able to break up those adhesions. So all of the other things that had been the result of the surgeries also were resolved. So it was a real success story. So pelvic floor physical therapists are a real valuable resource to have on for when this kind of thing occurs. Yeah, so I'm actually up to questions. How am I doing?
You are doing great. You have 7 minutes left on just the presentation part and then another 5. So you have 12 minutes total.
Oh.
And amazing, I will not be the first question asker because there's one in the chat. How about that?
Okay. I will, should I stop sharing my screen?
Oh, you can leave it up. It doesn't matter.
Okay.
The question from the chat is, what were the demographics of the sample?
So there was a range of ages. Trying to remember what the mean age was, I believe, in late 50s. But we had people who were in quite a range. And of course, that does complicate it because older people have sexual dysfunctions that come on from other things, and they're less able to rebound from interventions of various kinds. And what we're hoping is that in our next study, we'll be able to have a big enough sample that we can do things like look at age and so on. There weren't, I did show you the sex differences, and we didn't have enough in terms of race or other demographics to analyze them separately.
Okay. I have to tell you, you said something that just made me completely chuckle and go, oh my, shocking. Not really. Because it's something that as nurses, we see a lot that most patients were not going to ask their providers about sexual questions. You know, they're going to ask anybody else. And I can't tell you how many times, and I'm OB, a patient had a question, but they never asked the doctor. Like, you're right, they asked everybody else. So I can only imagine with the sex end of things, oh, but I'm not going to talk to him or to her. Do you find any difference if it were a female patient to a female doctor versus, you know, two different, you know,
oh, that's
male,
interesting.
female?
Yeah, I actually, in the literature I've read, they haven't made that distinction, but I would guess donuts to dollars that a female would be more approachable, because in my experience with sex therapy in general, everybody would prefer to talk to a woman therapist. Even the men want to talk to a woman about it. You know, you got to be their mom or something like that. I don't know. We're more approachable. We're trained to be relational. But yeah, they definitely, and I think part of what happens in the subtle exchange of the nonverbals is that, you know, the physicians are uncomfortable talking about it because of what the average number of times spent on sex in medical schools is like 3 hours in the entire time. So
Really?
People come out knowing nothing. I've actually had physicians in my practice, I had to teach about sex because they were having problems. So if you don't know, you're going to be uncomfortable. And if you're uncomfortable, that's going to get communicated non-verbally. Whereas other staff, nurses and so on and so forth they tend to be a little more holistic in how they see people. And I think they're more inviting. They feel safer because they're not so far up the scale of, what people.
A power imbalance.
Yes, the power. That was the word I was looking for.
There we go. Interesting. I don't know that I would have thought about the way I've probably gotten there, but that wasn't initially what hit my head. But oh yeah, absolutely.
But as soon as you ask the question, you invite the conversation. That's why it's so important to ask. And if you put it on the intake sheet, even the patient will check. Are you okay? How's your sex life? Whatever. A couple of questions. Do you have pain? Whatever. And if they check them, you can just bring it into the conversation, even if they say they have no problem. So I see you have no report. Do you have any concerns, pain, anything like that? And that opens the conversation. And when you open it, people are really grateful for it.
There's open-ended questions allowing people to kind of process and then start talking versus answering direct questions.
Right.
The pelvic floor PT, I have to tell you, I'd never heard of it before until I was in rehab for my shoulder. And the physical therapist and I was quite the snot, and I would not let a PT work with me. I'm like, no, I'm young. I want my shoulder function back. Only the PT can come in my room. I lost my mind one day because on day 3, I'd had yet a third different person. I'm like, no, this won't stop. But anyhow, that's a whole other story. But she and I got to know each other pretty well, and she had a certification in pelvic floor, and I'm like, oh, who knew? Who knew that was even possible? But I can see where it would be beneficial.
Yeah. And when you refer people to pelvic floor, you have to warn them that, it's kind of personally intrusive. It's like you go to a gynecologist to get a pelvic exam, they're going to be touching you. And this is what pelvic floor therapists do. They touch, they press, they spread, they're doing all that. They massage. So you have to be prepared for it. They got to understand they're going into something that is pretty intimate physically, right? But it's enormously effective. And we need more who do pelvic floor therapy.
Right. Needs to be the right fit, though. Just like your gynecologist, got to be someone you can deal with.
Yes. I think I haven't met a woman yet who did not want a female pelvic floor PT, for example.
Does not surprise me.
No, it's not.
Well, as always, I tend to be hogging the questions and the discussion. Anyone in the audience have anything to say? I love to chat and I love to learn new things. So probably puts me in a good spot as the chair and the moderator. But anyone else have anything to add or comments, questions?
I focused on brain tumor because of my connection to Dr. Fonkem. But the people I was seeing in the patient support groups, they were women's groups, and most of them had breast cancer they were dealing with. And since I have time, I could share a few stories about that show you how important it is to give them that kind of support. There were women in there who were just diagnosed and haven't had any treatment yet, all the way up to 20-year survivors. And the fascinating thing to me was how much they shared with each other when I was there to broach the subject. And so, for example, one of the things breast cancer patients deal with is the issue of to reconstruct or not. And talking about the importance of partners and people's sexuality, 2 women spontaneously, one said, well, my husband told me he loves me whatever I do, and so I chose not to. And the other one said, my husband really wanted me to have the reconstruction, so I did. And that's why I made that decision. So again, we tend to think of patients as isolated individuals, but they're not. They're in that kind of thing. And the other thing is that there's a lot of body image stuff involved with a lot of the cancers. I mean, ones like breast cancer are physically disfiguring, which is where the whole reconstruction thing comes in as to whether or not it's valuable. In the long term, there's a lot of differences in the long-term patterns of what you see in reconstructive surgery. But the other thing is that women don't know what to expect. And when you have a mastectomy, if you do the reconstruction, they're not going to be sexually responsive anymore. And when a woman has like a hysterectomy because of whatever reason, even if not cancer, but anything at all, a lot of women aren't told it's going to change their experience of sex, because your uterus is involved in the experience of orgasm. The pelvic floor and the uterus engage in synchronous muscular rhythmic contractions. That's a part of the intensity of the experience of the pleasure of orgasm. Well, you take a woman's uterus away, it's never going to feel the same. And I have found, this is where my thing about doctors comes in. I have found way too many doctors do not tell their patients, this is something you're going to experience. Right? So I think there's a lot of room for, just talking about bringing it in the room across a variety of things, not just the brain tumors that I study. Men with prostate cancer, they basically say your function is over. It's never gonna happen anymore. And I worked with a guy in particular. I remember that he was told that he's never going to be able to perform anymore. He's not going to be able to get erections and have intercourse. And he and his wife were just like really intense on making it happen, and they did. It's like, okay, so that there did get to be a point with enough radiation treatment where he did then start. But when he had the Lupron to block his testosterone because of the cancers and everything, they told him he's going to lose his, nothing's going to work anymore. And of course, his interest did go down, but he was still able to perform. So, sometimes they tell people things, and that's always a difficult thing. You want to help them be prepared for what might happen, but you don't want to tell them with certainty. I ran a focus group with brain tumor patients, and one of them had a glioblastoma, and she was told life expectancy is 14 months. She was now like 3 or 4 years past diagnosis. But what she described, it was wonderful in a focus group because it would never come out any other way. She said, when I got my diagnosis and they said 14 months, the death march began. Death march. All of her family were making time to come see her before she died. And God bless her, she had a good sense of humor about it, but underneath that humor was some pretty bad feelings, that they were all coming to see her one last time before she died, and yet she's still alive. So there's just being able to talk to people about what might happen, but also talking about, it can go this way or that way. And it takes time to have those conversations. I know with the medical situation that we're in now, with the time people have for talking, it's really difficult to squeeze all that stuff in. But I think that's one of the values of multidisciplinary teams, that you can bring in the counselor or social worker, whatever, who can talk about all this stuff with them, or bring in the pelvic floor therapist, or bring in whatever. That working as a team is really valuable. The person is not an individual by themselves. They're not just,
And maybe that humor was that she had enough time post the hurt, and it's how she resolved it. I'm part of a humor therapy group, and that's one of the things, you as the one experiencing the hurt, when you get so far past it, you can look back and then laugh. It then becomes the true funny, and the humor is how you helped deal with it. So when you say that, I'm like, yeah, I can see that. And she's the only one that can laugh about it because it was her. But wow.
I agree. And I'm sure she didn't refer to it as a death march while she was experiencing it. In that first year, that when everybody was coming, I'm sure she did not use that phrase. But it came to her afterwards as a way to, you're right, there's a way to, a lot of times what we experience itself isn't so important. It's the perception of it and how we integrate it into our lives. And I think she's a good example of that.
Absolutely.